The cough stopped. After weeks, sometimes months of that dry, scratchy, relentless tickle that no lozenge could soothe and no position could escape, it simply went away. Your body had adjusted. The medication had settled in. You felt relieved. You stopped thinking about it. And nobody told you that the disappearance of that cough can sometimes be exactly the moment to become more careful, not less. I'm Dr. Eleanor Bennett. Subscribe to this channel before we go any further, because what I am about to tell you is one of the most important things any senior on Lisinopril can know. Not the most common thing, the most important. The thing that separates a medication nuisance from a potential medical emergency. And the thing that most patients, and genuinely many prescribers, do not communicate with the clarity and specificity it deserves. Let me start at the beginning, because to understand what happens after the cough, you need to understand what the cough actually is. Lisinopril is an ACE inhibitor, an angiotensin-converting enzyme inhibitor. It lowers blood pressure by blocking an enzyme that produces a hormone called angiotensin II, which tightens blood vessels. Block that enzyme and the vessels relax, resistance falls, and blood pressure drops. That is the intended mechanism. Clean, logical, effective. But that enzyme also breaks down a substance called bradykinin. Bradykinin is a signaling molecule that, among other things, causes inflammation and sensitizes nerve endings. Under normal circumstances, the ACE enzyme keeps bradykinin levels in check. It degrades bradykinin before it can accumulate to levels that produce symptoms. When ACE is blocked by lisinopril, bradykinin accumulates. In the airways, accumulated bradykinin irritates the nerve endings in the throat and bronchial lining. The result is the dry, persistent, non-productive cough that affects somewhere between 10 and 30% of people who take ACE inhibitors. This cough is not allergic. It is not infectious. It is pharmacological, a direct consequence of the medication's mechanism acting on tissue it was not designed to target. It is real. It is miserable. And it is one of the most consistently under-recognized medication effects in senior health, arriving sometimes weeks or months after starting the medication, which is why patients so often fail to connect it to lisinopril. And then, in some patients, it stops. Why does the cough stop? Sometimes the body genuinely adapts the nerve sensitivity in the airways, reduces over time, and the bradykinin accumulation, while still occurring, no longer produces symptoms at the threshold required to trigger the cough reflex. In these patients, the disappearance of the cough is benign. The medication continues to work. The cough, as an annoyance, has resolved. But here is what nobody tells patients in that moment of relief. The accumulation of bradykinin that caused the cough has not necessarily stopped. The mechanism that was producing the cough is still present. And in some patients, not all, but some, that mechanism quietly shifts its expression from a cough to something far more serious. Let me tell you about the condition that can follow the cough. Let me tell you about angioedema. Angioedema is a swelling that occurs in the deep layers of the skin and the mucous membranes below the surface, in the subcutaneous and submucosal tissue. It can affect the lips, the tongue, the face, the throat, and in some cases the intestinal walls. It arises from the same bradykinin accumulation that produces the cough, but instead of irritating nerve endings in the airways, the accumulated bradykinin is triggering increased permeability in the blood vessels of the deep tissue, causing fluid to leak rapidly into the spaces beneath the skin and mucous membranes. ACE inhibitor-induced angioedema affects a smaller proportion of patients than the cough, perhaps 1 in 1,000 to 1 in 500, depending on the population studied. But in the context of how many millions of seniors take ACE inhibitors, that proportion represents a very large number of people. And the condition it produces is not a nuisance. It is a potential airway emergency. When angioedema affects the tongue, it swells. The tongue becomes thick and large, difficult to manage inside the mouth. When it affects the throat, the posterior pharynx and larynx swelling begins to narrow the airway. Breathing becomes effortful. The voice changes. Swallowing becomes difficult. And if swelling continues unchecked, the airway can close. This progression from the first awareness of something unusual in the mouth or throat to a critically compromised airway can occur in minutes to hours. It is not uniformly rapid. Some cases progress slowly and give significant time for intervention. Others progress with a speed that demands immediate emergency treatment, and the person experiencing it cannot know in the moment which trajectory they are on. This is why angioedema on lisinopril is not a symptom to observe and monitor at home. It is not a call the office in the morning situation. It is not a let me see if this gets better situation. It is call emergency services now, while there is still airway, while treatment can still be delivered without intubation, while the window in which epinephrine and airway management are straightforward rather than desperate is still open. Let me tell you about Catherine. Catherine was 69 on lisinopril for 3 years. She had had the cough in the first month, a miserable, sleep-disrupting cough that had gradually faded over the following 6 weeks. She had been relieved when it resolved. She had told her doctor it had gone, and her doctor had been pleased. No further discussion about airway symptoms had occurred. On a Tuesday evening in her 3rd year on lisinopril, Catherine noticed that her lower lip felt thick. She pressed it, and it felt different from usual. Fuller, slightly firm beneath the skin. She assumed she had bitten it without noticing. Over the next hour, the lip swelled visibly. She took an antihistamine, which she had read was used for allergic reactions. The swelling did not improve. By the 2nd hour, her tongue felt enlarged inside her mouth. She had mild difficulty swallowing her saliva. Her husband drove her to the emergency room. By the time she arrived, her tongue had swollen significantly, and her voice had changed to a hoarse, muffled quality that the emergency team recognized immediately as a sign of laryngeal involvement. She received epinephrine and was monitored closely. She did not require intubation. She recovered. But the trajectory she was on, had her husband not insisted on the emergency room when he saw her tongue, was toward an airway that was closing. The antihistamine she had taken, while appropriate for allergic reactions, does not effectively treat ACE inhibitor-induced angioedema. This is a critical point that most patients do not know. Allergic angioedema is driven by histamine. ACE inhibitor angioedema is driven by bradykinin. Antihistamines block histamine. They have minimal effect on bradykinin-mediated angioedema. A patient who takes an antihistamine for ACE inhibitor angioedema and waits to see if it works may be waiting while the swelling continues, not because the antihistamine failed, but because it was never the right tool for this specific mechanism. Catherine waited an hour with an antihistamine before going to the emergency room. In that hour, her swelling progressed from a lip to a tongue to early laryngeal involvement. Had she gone immediately? Had she known that lip swelling on lisinopril is a call emergency services symptom, rather than a take an antihistamine and wait symptom? The trajectory of that evening would have been less frightening, and her airway less. Compromise on arrival. Now let me tell you the timing truth that most patients on lisinopril do not know, and that fundamentally changes how they should think about this risk over time. ACE inhibitor angioedema is not primarily a first week's phenomenon. It is not the kind of reaction that appears only when the body is first encountering the medication. It can appear at any point during treatment, after months, after years, sometimes after a decade of uneventful use. The two are related mechanisms, both driven by bradykinin accumulation, but they are not interchangeable. A patient who had the cough and whose cough resolved is not immune to angioedema. A patient who never had the cough is not immune to angioedema. The risk persists for as long as the medication is taken. This is one of the most important timing facts in all of medication safety for seniors. A patient who has been on Lisinopril for 5 years without incident cannot reassure themselves that the risk has passed. The risk is present today exactly as it was in year 1, and the vigilance appropriate for recognizing early angioedema symptoms, the lip fullness, the tongue thickness, the throat tightness, the change in voice belongs in year 5, as much as it belonged in week 1. Let me tell you about Frank. Frank was 72 on Lisinopril for 7 years. He had never had the cough. He had never had any side effect he associated with the medication. He considered himself, with 7 years of uneventful use as evidence, to be someone who tolerated Lisinopril well. He had no reason to think about angioedema. Nobody had given him one. One morning, Frank woke up with a swollen tongue. Not dramatically swollen, just fuller than usual, with a slight difficulty moving it the way he normally would. He assumed he had slept with his mouth open and his tongue had dried out and irritated. He drank water. He waited. Over the following 2 hours, the swelling increased. He noticed his voice had changed slightly hoarse, slightly muffled, different from usual. He called his wife, who took one look and called emergency services. Frank was treated and recovered. But the 7 years of uneventful use that had made him feel immune to this risk were irrelevant to the mechanism that produced that morning's swelling. Bradykinin accumulation had been present throughout those 7 years. On that particular morning, for reasons that are not always fully explained, though factors like concurrent NSAID use, certain illnesses, and individual variation in bradykinin metabolism are implicated, the accumulation crossed the threshold that produced angioedema. 7 years of safety had not reduced the risk. It had simply not yet materialized. Now, let me be clear about the distinction between symptoms that warrant vigilance and symptoms that warrant immediate emergency action, because I am not asking you to live in fear every time your throat feels slightly dry. The symptoms that are ordinary and do not require emergency action: a dry cough, a throat tickle, mild hoarseness that has been present for days and is not worsening. These deserve mention at a routine appointment. They do not demand an emergency response. The symptoms that require immediate emergency action: sudden swelling of the lips without a clear local cause, the tongue feeling larger, thicker, harder to move, throat tightness, a new sensation of narrowing or constriction, a sudden unexplained change in voice quality, difficulty breathing accompanied by any of the above. These symptoms, any one of them, escalating or new, are the signal to call emergency services, not the signal to take an antihistamine and observe. The signal to say, I am on an ACE inhibitor called Lisinopril, and I am having swelling of my lip and tongue. I need help. Those words, I am on an ACE inhibitor, change what the emergency team does in the first 60 seconds. They trigger a specific protocol. They alert the team that antihistamines alone may be insufficient. They communicate that epinephrine and airway management tools need to be immediately available. Information delivered in the first minute of an emergency call can change the entire trajectory of what follows. There is a face of ACE inhibitor angioedema that almost nobody knows about, and that sends thousands of seniors to emergency rooms every year with a diagnosis that is not connected to their medication until sometimes the 3rd or 4th episode. Intestinal angioedema. The same bradykinin-driven fluid leakage that can swell the lip and tongue can also affect the wall of the intestine. When the intestinal submucosa swells, the bowel becomes edematous and temporarily dysfunctional. The result is sudden, severe abdominal cramping, often colicky, coming in waves, sometimes accompanied by nausea, vomiting, and diarrhea. It can be debilitating. It can mimic appendicitis, bowel obstruction, or other acute abdominal emergencies. And because the face and throat are not involved, the connection to lisinopril is almost never made on the first presentation. Seniors with recurrent episodes of unexplained severe abdominal pain, particularly if the pain resolves completely over hours and leaves no detectable cause on imaging, should have their medication list reviewed specifically for ACE inhibitors. The pattern of episodic severe self-resolving abdominal pain in a patient on lisinopril is highly suggestive of intestinal angioedema, but it is diagnosed correctly, on average, after multiple emergency visits, extensive workups, and sometimes unnecessary procedures. Because the possibility of ACE inhibitor involvement is not the first thought in an abdominal emergency room. Patricia was 71 and had attended the emergency room 3 times in 18 months with severe abdominal cramping that resolved within 6 to 12 hours. Each time, imaging was normal. Each time, she was discharged without a clear diagnosis. On the 4th visit, a physician who happened to notice lisinopril on her medication list asked whether anyone had ever considered intestinal angioedema. The answer was no. Lisinopril was stopped. Patricia has had no further episodes in the 2 years since. 3 emergency room visits. 18 months. Extensive imaging. 1 medication question that changed everything. Let me also tell you about the patient who switches from lisinopril to an ARB to losartan or valsartan because of the cough. Because this is a common and usually sensible clinical decision, but it comes with a nuance that deserves its own moment. ARBs work by blocking the receptor that angiotensin II acts on, rather than blocking the enzyme that produces it. Because they work downstream of the ACE enzyme, they do not cause bradykinin accumulation the way ACE inhibitors do. The cough, which is bradykinin-driven, typically resolves. This is often the reason the switch is made, but in patients who have had ACE inhibitor angioedema, not just the cough, but actual swelling episodes switching to an ARB is more complicated. There are documented cases of ARB-associated angioedema, though the mechanism is different and the incidence is lower. A patient who has had a serious angioedema episode on lisinopril is not automatically safe on losartan. That transition requires an explicit clinical discussion about residual risk, about the monitoring approach, and about what symptoms should trigger an immediate response. If you have switched from lisinopril to an ARB because of the cough, and you were never told that angioedema risk is a separate conversation from cough risk, you now have information that belongs in a conversation with your prescriber before your next dose. Let me tell you about the factors that appear to increase the risk of ACE inhibitor angioedema, because understanding them gives you one more layer of practical protection. Race is one of the most consistently documented risk factors. Black patients have a significantly higher rate of ACE inhibitor angioedema than white patients. Estimates range from 3 to 5 times higher. If you are a Black senior on lisinopril, this is not a reason to stop without guidance. It is a reason to be specifically informed about the symptoms and to ensure your prescriber has this context. Concurrent NSAID used regular ibuprofen or naproxen appears to increase angioedema risk. A senior taking over-the-counter pain relievers regularly alongside lisinopril is adding a variable that belongs in the medication conversation. A prior history of unexplained swelling of the face, lips, tongue, or extremities at any point in life without a clear allergic cause significantly increases risk. That history belongs in your medical record. And certain illness states, acute infection, surgery, physical stress appear to trigger angioedema in patients who have been stable on ACE inhibitors for years. The medication did not change. The internal environment around it did. So what does all of this require of you? Practically, It requires knowing the difference between the cough and the swelling, not in a vague, general way, but specifically enough that when a lip feels fuller than usual on a Tuesday evening, you do not spend an hour with an antihistamine wondering if it will pass. It requires knowing the words to say if the moment arrives. I am on Lisinopril. I am having swelling of my lip and tongue. I need emergency help. Those words trigger a specific protocol. They tell the emergency team that antihistamines alone may be insufficient and that epinephrine and airway tools need to be ready. It requires not being reassured by years of uneventful use. The mechanism is present every day. The risk does not diminish with time. And it requires a brief conversation at your next appointment to confirm that your prescriber has your ACE inhibitor status clearly documented so that any emergency care you ever receive begins with that information already in context. The cough that stopped felt like relief. It was relief. And it is also the moment that requires a different kind of attention, not panic, but precision. The precision of knowing exactly what symptom changes the category of what you are experiencing, from a nuisance to an emergency. Now you know. Carry it with you every day that you take this medication. Not as fear, as preparation. Share this with every senior on Lisinopril who thinks the risk was over when the cough stopped. Subscribe to this channel, and I will see you in the next video.